Within the acetabulum, you have a triangular fibrocartilage. It's attached at its base to the rim of articular cartilage surrounding the perimeter of the acetabulum. At the inferior acetabulum, the labrum is absent where the transverse acetabular ligament completes the circumferential rim. It's thinner in the anterior inferior portion of the acetabulum, thicker and slightly rounded in appearance posteriorly. The role is to deepen the acetabulum, which assists in the constraint of the femoral head in the bony socket. It also functions to decrease contact pressure. So it reduces contact stress by increasing contact area and by distributing the load. It also aids in distribution of synovial fluid and joint lubrication, provides a joint seal, and also includes mechanoreceptors for pain, pressure, and deep sensations. Your hip relies on the labrum, joint capsule, and ligaments for stability. The anterior orientation of the acetabulum and femoral head is set up so that the femoral head has the least bony constraint anteriorly. The hip joint contact forces are anteriorly directed in the last 20 to 30 degrees of the stance phase of gait, and so your anatomical loads lead to an increased stress on the labrum, especially anteriorly, which is where you have your highest incidence of tears. For an acetabular labrum tear, the mechanism of injury usually involves a twisting or falling that results in an external force on the hyperextended, externally rotated hip. So you will see this in running and rotational sports such as soccer, hockey, golf, or ballet. It often presents with initial diagnosis of a groin strain with no specific trauma. Signs and symptoms will include mechanical symptoms such as a catching, painful clicking or snapping, or a giving way of the hip. We have to look at the three different types of sources of snapping hip syndrome, such as external, internal, and intra-articular, such as discussed during the previous external snapping hip syndrome. You can see that labrum or ligament tears are going to be most likely intra-articular snapping. In addition to this, the person may give you the C sign, and the C sign is literally a C with your hands pointing to that part of the hip. The patient will complain of dull, activity-induced positional pain that fails to improve with rest. During acute bouts, there will be sharp, dysfunctional pain. It presents in the hip as well as the low back and groin. There will be decreased activities of daily living, and the person may be dysfunctional in weight bearing. Range of motion will be decreased for the hip in both active and passive range of motion. A special test that can be performed is called the IRF axial compression maneuver. Your patient is supine, you flex and internally rotate the hip and provide an axial compression through the femur. Diagnosis is going to be clinical, but MRI or CAT scans can be used. An X-ray may also be performed, but all three have low sensitivity and specificity. If there is a tear, the treatment for hip pain that has been going on for longer than 4 weeks is going to be a recommended arthroscopic surgery. It is one of the most common indications for outpatient hip arthroscopy, and the surgeon will go in and debride the torn labrum and suture anchors or sutures to reattach the labral tear. With this surgery and or condition, there will be long-term outcomes. There will be associated articular cartilage lesions. There may be subchondral cysts, and you may find that the person ends up with degenerative joint disorders, especially tears that have been there longer than 5 years.